Thanks again to both of you for joining the advisory board meeting. You guys so far have made, great contributions and ideas to our sort of clinical thought leadership here at Prevounce. And again, I really appreciate your time here over the last year and for the years to come. I guess we're transitioning specifically to talking about two things: value-based care, as well as Medicare payment models. So the specific question is, the ambulatory specialty model is a sort of new niche model that's come out. I was just wondering if you guys have heard about it or, if you've had any thoughts on it.
Yeah, I think it's going to accelerate the use of RPM drastically. As I'm familiar with it, it's, I think, targeting uh, providers that are dealing with patients with heart failure and with low back pain, both of which are probably two of the most common complaints that come in to seek care, either in the outpatient setting or in the inpatient setting. And I believe that this new model that kind of uh, reimburses for sort of an entire episode of long-term care for these pathologies is going to incentivize the use of RPM the moment that the patient leaves the hospital. So when we have patients with heart failure exacerbations and we give them, a little bit of diuretic in the ED, and then they, with hopes of them going home and following up their cardiologist to avoid a hospital admission, I think having infrastructure to incentivize long-term monitoring for these patients is going to really, I think, encourage the use of RPM the moment those patients hit the door, the moment those patients walk out of the door. Similarly for low back pain, for which patients could be suffering for months on end and have repeat visits to the emergency department. I think there's going to be a lot of incentive to have those patients be monitored over a period by a pain specialist or by their primary care doctor, instead of having them come back to the ED for episodic care that um, may not be well monitored long term.
Perfect, and Dr. Wang.
Yeah. So I think this change, just zooming out over the last 5 to 10 years, a lot of emphasis has been on making sure that the economics of healthcare don't just match with doing surgery or doing treatment or prescribing medication, and really matching with actually getting patients better and healthier. And this is, in my opinion, just a step forward in that direction, where we're not just looking at, does patient have low back pain, right? And therefore, anesthesiologist, pain specialist perform a spinal cord stimulator or another procedure or a prescription, and then get reimbursed for it. It looks a lot more at the quality of care that's delivered, at the outcome of the patient, and the payment is adjusted based on that patient outcome. And I think that the all of medicine is going in that direction. And so how this pertains specifically to RPM, I think RPM is this, this change doesn't say anything about RPM or not, but what it allows is a niche where an RPM infrastructure now has a space to take over to potentially add value to a pain specialist who does specialize in low back pain, right? Not only now are you prescribing medication or doing a surgery or whatnot, but now you also are responsible for monitoring the patient afterward and seeing how they're doing, and you're being appropriately reimbursed for doing that. So overall, patient care improves when that happens.
Building on that question, and you both got into this a little bit, and just wondering if you guys had any further thoughts on this. In terms of specific quality metrics or outcomes, specific quality metrics or outcomes in terms of, integrating RPM and things to prioritize. Yeah, I guess an example that I'd give you is, one that you guys already mentioned in terms of heart failure hospitalizations. You get maybe reimbursed based on sort of metrics from that standpoint. If your patients are getting readmitted to the hospital for exacerbations of heart failure. You see it in the internal medicine space as well. One thing when I was doing ambulatory clinic in internal medicine, they would actually go through all of my patients and see how many patients were not meeting specific metrics in terms of blood pressure management and systolic blood pressure goals. Initially I had mixed feelings on this just because, I didn't like being micromanaged, and I didn't like, I was doing my best in terms of managing these patients, and, I didn't like, somebody else coming and analyzing my data and giving me suggestions. But, overall thinking about it sort of from a broad strokes perspective, it was helpful because, once I did see those maybe gaps in care, I did go and fix those and sort of implement change. So I guess from that perspective, so I mentioned a couple of examples from the heart failure perspective, blood pressure perspective that you see in sort of the ambulatory side. What are some metrics that you guys think are important on the clinical side that should be adopted in terms of these sort of value-based RPM and metrics-based workflows?
There's the patient-centered metrics, and I think then there's well, I should say there's the patient quality of life metrics, and there's sort of the medical metrics. Like you mentioned already, kind of the blood pressure parameters, things like that. For example, post heart failure admission, discharge time to GDMT initiation, or things like that. I think that's one subset, but the other subset I think is probably more relevant to speak in broad strokes is the number of unexpected visits for care, because unexpected visits I think are the most costly. So in particular, emergency department visits, urgent care visits, and then also I think just sort of a very generic metric of time at home. So the amount of time that patients spend at home in 60 days post hospital discharge probably encompasses what matters the most to patients, which is not having unexpected interruptions to the day-to-day life, to have a more nuanced care model that intervenes before a crisis happens where they have to uproot their life and come into the hospital and leave home.
What about you, Dr. Wang?
Yeah, so I think that, one of the key things that we look at for patients who leave the ICU or leave after any big surgery from the OR is complication rate and readmission rate, right? And so one of them, for example, is 30-day readmission rate. We're always talking about that in all contexts. And I think specifically in, I'll bring up an example actually. So post-cardiac surgery, there was actually a really good study in a couple years ago, I believe it was 2024. They looked at 1,000 cardiac surgery patients, and they had control group that normal workflow, stayed in the hospital and discharged home, and then the treatment group, which was discharged with RPM. And the treatment group showed 33% relative reduction in 30-day readmissions, right? And actually 1 day shorter median postoperative length of stay. And so to me, that's the most impressive thing, right? You actually show that you made a difference in patient outcomes. And I think what RPM does is it fills the gap, which is right now patients who are in the hospital, in the operating room, and then ICU, and then the floor, they're all watched very, very closely. And then all of a sudden you go home and it's like you fall off a cliff, right? And then you're not seen again until, your outpatient visit, which might be a few days, might be a few weeks. It totally depends on, what's going on. And then anything in between there, if something goes wrong, nobody knows. And you only know if you have symptoms, and then you represent to the hospital. And then we have to go through a whole workup and figure out what happened. And so that's the space that RPM can really capture.